start and to ask Michaela to give her talk, pacing maneuvers during sinus rhythm, all the stuff that is listed up here. And we are looking forward to your presentation, Michaela.
Thank you very much, Philip and Marta. Good afternoon, everyone. Thank you also very much to the organizing committee for having me for this talk. Well, my topic is pacing maneuvers during sinus rhythm, and I will include atrial and ventricular extrastimuli, parhesian pacing, and apex to base differential pacing. Some of my disclosures. And I'd like to start right away with this ECG of a young gentleman that came to our emergency department with this narrow complex tachycardia with 160 beats per minute. And there is basically three major SVT mechanisms that we need to be able to distinguish, and it includes AV-RT, ectopic atrial tachycardia, and AV-NRT. And if you bring the patient to the EP lab, pacing maneuvers during sinus rhythm may really help you to distinguish those, in particular if these arrhythmia involve septal substrates. And also when you bring your patient to the lab, and if you do an EP study, it's very important to have an SVT workflow of your own, and I like to share mine with you. And with regard to the topic of my presentation, we'll focus on the maneuvers during sinus rhythm, which include the evaluation and the study of AV conduction, but also others. And while some maneuvers are really mandatory to understand how the heart is wired, some are rather optional or become of importance under circumstances that we will discuss in a minute. So let's start with the pacing. At the beginning of an EP study, I always want to know first, is there retrograde conduction at all? Because if there is not, AV-RT is highly unlikely. So we start with incremental ventricular pacing and just observe where is our earliest retrograde atrial activation. But be careful not to jump to conclusions if you don't have VA retrograde conduction, because some accessory pathways and also some nodes really require the catecholaminergic kick. So make sure that you repeat this maneuver also with isoprenolone to make sure that there's really no VA conduction. So in the case of the gentleman, we did incremental ventricular pacing and observed where is the retrograde atrial activation. Already you can see that with by pacing with 290 milliseconds, you don't have a typical concentric retrograde activation. It's rather banana-shaped here on the CS. So it's not midline and concentric, and with further increment, it becomes clearly eccentric. So you can see that the earliest activation is really on CS1, on the distal CS catheter. And this can be explained by the fact that during slower drivetrains, the atria are activated first via the AV node and only later via the accessory left lateral pathway in this case, and you get fusion somewhere in the atrium, which corresponds to this kind of CS activation. With more rapid ventricular pacing, you create more delay in the AV node, and which results in a clearly eccentric atrial activation over the left lateral pathway, resulting in this eccentric activation. So having done that, we need to know if AV conduction is decremental or not, and therefore we give 8 extra stimuli here in a row and couple it with a fixed cycle length, for example, with 600 or 500, and then we couple an extra stimulus with S2, for example, with 350. We can start with 350, and then we increment by 10 milliseconds per drivetrain, and just observe what happens with retrograde activation after introducing this extra stimulus. Is it concentric and is it decremental? And if, in this case, the retrograde VA conduction is solely over the AV node, we'll see a propagation we will see a VA interval that will get longer with every extra stimulus that you introduce. You see here we have a coupling interval of 280 in the ventricle. You get a VA that is 160, and if we decrease this further, we get a VA interval that prolongs. This is because of the decremental conduction properties of the node. And we can state that the activation is decremental and concentric, which is rather unlikely for an accessory pathway. And how about this one? This is the case of the gentleman I showed you the ECG from, and we do the same thing. We add an extra stimulus, go down from 320 in this case to further down to 300 to 280 and so on. But the VA interval stays really fixed. It stays 150, which is logical because you have a left lateral accessory pathway, so you can state that your VA conduction is fixed and eccentric. Okay? Having then programmed ventricular stimulation, we do the same maneuvers from the atria. So we perform incremental atrial pacing with a fixed drivetrain and then add one extra stimulus and observe if we have dual nodal AV physiology enabling AV NRT, for example. And therefore we observe an AH of 250, and then the next drivetrain we decrease the S2 by 10 milliseconds, here in this case 400, and we get an AH jump of 352, so clearly more than 50 milliseconds. That would be the definition of an AH jump. Sometimes you also get atrial echoes, or even can induce the tachycardia, like it was the case again in the case that I presented to you earlier with the ECG. And in the presence of such an eccentric activation with a previously demonstrated eccentric and fixed or non-decremental conduction properties, I think the mechanism of the tachycardia is quite easy to establish. But if you cannot induce the tachycardia as easily, or if you have a nearly concentric activation, if you pace in the retrograde atrial activation, you might need other maneuvers to establish the correct diagnosis. And with that regard, two maneuvers may be particularly helpful, in particular in the context of concentric retrograde activation, or if you are in doubt if you have a parahesian or paraseptal accessory pathway. And these are parahesian pacing and also differential RV pacing. We will start with the parahesian pacing, and the concept is actually quite simple. If you position a catheter to record a stable retrograde His and an atrial activation, you start with high output pacing, ideally with 20 milliamps, for example. Unfortunately, some stimulators are not able to do so, so we, for example, have to start with 10 milliamps, but the highest output you can get. But make sure that you capture really the septal RV myocardium and the His bundle directly, because there might be some pitfalls that I will just comment on in my next slide. And that pacing will result in an antegrade ventricular activation with a narrow QRS complex, because you directly capture the His here. With gradually reducing the pacing output until the His bundle will no longer be invaded, your impulse will have to travel all the way down the septum to invade the distal part of the His Purkinje system and go down up to the node in order to conduct retrograde through the atrium, and that will result logically in a broadening of the QRS complex and the prolongation of the stimulus TA. So in this example, we start with high output pacing. We get an SA of 190 milliseconds, and the further you reduce your output, you get a prolongation of the SA interval because your impulse has to travel that way. And the opposite is the case, of course, if you pace close to an accessory paraseptal pathway. It does not really matter with what kind of output you pace, because your VA conduction will always be over the node. So if you reduce your, over the pathway, because reducing your output in pacing will always result in the same stimulus TA pacing no matter if you capture directly also the node or if you capture the myocardium simultaneously. The concept is easy, but there are a few caveats and many confounding factors. And for me, the most difficult part of it is actually to achieve a consistent His bundle capture because of respiration, because of the heartbeat, because of catheter stability. And so you really have to be very careful and look what you capture, because you might really get a lot of fusion sometimes that might confuse you also interpreting the results of parahesian pacing. The other maneuver that I mentioned was differential apical or differential apical base pacing, and that's also a very helpful maneuver that might help you to differentiate anteroseptal pathways from an anterior AV nodal exit side. It might confuse you when you pace in the ventricle or get a slightly leftward directed atrial activation over the CS. And the concept is, to pace in the ventricular RV apex and compare the duration of the stimulus or of the VA interval with the VA interval that you create during RVOT basal pacing until the atrial are entrained at the pacing rate. And basically, if there is no accessory pathway and VA contaction is solely over the node, your impulse again will have to travel much shorter if you pace in the apex to the base than if you pace at the base, because will take much longer to pace from the base until you invade the distal His-Purkinje system and reach the atria. That will result in a delta of your VA interval of less than 10 milliseconds, and the opposite will be the case. Obviously, if you pace at the base, you will be much closer to the accessory pathway, so your VA will be much shorter, and it will be accordingly much longer if you pace in the apex and need to activate the atria retrogradely. So I would like to conclude that in particular if pacing maneuvers during SVT are inconclusive or just not possible because you cannot induce SVT or only non-sustained and cannot perform pacing maneuvers during SVT or repeatedly terminated, or if you are in doubt that you have a paraseptal pathway, pacing maneuvers during sinus rhythm might be particularly helpful and actually also mandatory to study the baseline conduction properties in every EP study. And I thank you for your attention.
Thank you, Michaela. It's really, in a way, a difficult task to explain something to people which everyone thinks, at least, to be fully aware of. But I can tell you that this is maybe not always the case, and especially what I find helpful if you have a standardized approach in your lab. So a patient comes in and you always do basically the same stuff, and I think you nicely showed that. May I ask a first question? And also you can stand up, come to the mic, and you can also type your question into the app if you have one. Can you tell us about your standard catheter setup in a patient like this? Do you always start with the coronary sinus catheter, steerable catheter, or what's your standard catheter setup? Because I think also this has a high variability.
That's true, yeah. We have always a minimum of 3 catheters for every SVT. We try to have a temporal CS catheter to have like the left atrial part, shown. Sometimes if it's difficult, we have always an RV, 4-polar RV catheter, and of course also a His catheter. And what I also observe very often with my, with also younger fellows or so, it's very important to use all the information that you have, because very often they only put like the distal poles, let's say. But I mean, we're talking about using multipolar catheters for SVT ablation, and then we don't even use the information that we can have. So always make sure that you have the distal and the proximal poles of your 4-polar catheters. I think this is very important also to keep that in mind. But to answer your question, sometimes we also put an HRA catheter additionally if in doubt, but typically 3. Yes.
Great presentation. Thank you very much. I have 2 questions.
Yes.
First one, if you have no retrograde conduction, do you still do parahesian pacing?
That's a difficult one. It depends also, because as I said, sometimes also retrograde conduction can be highly variable on your vagal tone. And yes, we do it because, of course, but you can also be confused with fascicular pathways or nodal fascicular, but it's difficult to interpret, I must agree.
The second one, if you only have, like during the study, you only have like retrograde jump. And how do you interpret that? That, like, if you have a patient with a known SVT in the EKG, do you consider that as a dual AV node physiology and you do the ablation of the slow pathway? Or you just say, okay, we don't have a reason for the ablation?
It's a very good question, and I think it's not mandatory to have an AH jump. It's also either antegradely or retrogradely. Thank you for that question, because basically you still can have presence of dual nodal AV physiology, because the refractory periods of fast and slow pathway can be very close to each other. So it's not mandatory to have that. So in doubt, I mean, if you have documentation of an SVT and you do all your maneuvers, and even, you know, typically we do also, of course, the maneuvers during tachycardia, but if you don't, we have to discuss critically with the patient. I mean, if it's the most common thing to have an AVNRT if you have the documentation, and if all your maneuvers point towards an AVNRT, I would do ablation, yes.
Can I throw something in? So you have to be very careful when you interpret a retrograde jump. Retrograde jump is usually the right bundle blocking. So you may have the conduction through the AV node. It goes through the right bundle, straight in through the AV node. When the right bundle blocks, it's now got to go through the septum, through the left-sided Purkinje system, and up. That's a jump, but it's not a jump between the H and the A. So you have to be careful that you're not misinterpreting a jump retrograde as AV nodal jump. And so the way to do that is to be able to record a His bundle and see it. You'll see the His jump out retrograde when the right bundle blocks with a premature. So.
Thank you. Yes, because also very often the His is buried within the ventricular signal. Right? Yep.
Now, wonderful. Thank you very much.
Thank you.
Now, it is my pleasure to introduce the next speaker, Dr. Rachel Terbeke from Maastricht, and she's going to talk about atrial pacing maneuvers.
Thank you. Yeah, there's my screen. Thank you, Marta. Thank you for having me on stage here. And it's a pleasure for me to share with you my approach to atrial pacing in patients with SVT. I have nothing to declare. And just as an overview, there are, of course, many SVTs that we can target, but I will not talk about atrial tachycardia, AFib, or atrial flutter. Instead, I would like to have with you, talk with you about AV nodal reentrant tachycardia and how we can understand those in comparisons to junctional tachycardias or even AV nodal reentrant tachycardias, both antidromic and orthodromic. And in the end, I will slightly touch upon differential diagnoses with atrial pacing on aberrancy and VT. So as Marta and Mika already nicely showed you, the AV node is a very important structure that you need to understand when you are pacing in the atrium. So the fast pathway is located superiorly to the triangle of Koch. And the slow pathway is somewhat inferiorly anterior to the also the sinus, coronary sinus. So if you do decremental atrial pacing, or if you give atrial extrastimuli, of course we know that the AH jump is a very indicative finding of dual AV nodal physiology, but as we learned from the previous speaker, there may be a gradual AH increase without a 50 millisecond increase upon pacing. Furthermore, it is known that only 83% of patients with AVNRT do have a jump. So you might miss your jump when you are not aware of this. And even so, patients without AVNRT also regularly show dual AV physiology. So that's important to keep in mind. And this is another feature that we often see in patients with AVNRT. Upon atrial extrastimuli, the first atrial extra stimulus will go over the fast pathway with a long refractory period, and the same stimulus will be delayed over the slow pathway and will reach the HIS for a second time and activate the ventricle for a second time. So this is a very typical feature that you often see. And it's called 2-for-1 or double fire or AV nodal response. And as you can see in the final beat, there is an AV nodal echo that is going retrogradely over the fast pathway that has recovered from the long previous interval. Now, it's always important to look at the retrograde, the first retrograde atrial activation, because it tells you something of the localization of the retrograde pathway. Is it the fast pathway or is it the slow pathway? The fast pathway will have the first atrial activation in the region of the HIS, it's higher up, and the slow pathway will be lower towards the also the coronary sinus. So what else can we do in sinus rhythm? Of course, we can perform incremental atrial pacing, and sometimes you see suddenly a pre-excited QRS complex occurring. So this is something that's also important to take along. Usually these accessory pathways are located far away from the AV node, so they need some delay in the AV node to become apparent, or you have decrementally conducting accessory pathways like in Maheim, and then you need also to slow down the AV node to make it apparent. But this is the same as for the dual AV nodal response. It doesn't prove that this is the tachycardia that you need to ablate. So it's always important to have a tachycardia ongoing and perform additional measurements within the tachycardia. So one thing you can do, so what you see here is SVT with a short VA interval and HIS preceding the A and the V. So it could be either a junctional tachycardia or an AV nodal tachycardia, a slow fast AV nodal tachycardia. So what you then can do is to give atrial extra stimuli during HIS refractoriness. So here you see exactly on the HIS we paste in the proximal part of the CS, and then what you will do is to interrupt the retrograde fast pathway conduction towards the atrium. And this will then find the slow pathway excitable again. Usually it will travel it will allow the wave to travel to the HIS bundle with a slight delay, but because you stimulated earlier, the subsequent H interval may be or should be a little bit shorter. So if you are able to reset the next H after your atrial stimulus on HIS refractoriness, this is an argument for slow fast AV NRT. And this is the Lewis diagram that goes along with it. You pace during HIS refractoriness, the fast pathway blocks retrogradely, and you invade the slow pathway for a second time, allowing the subsequent HIS to become earlier. This is in contrary to what would happen if you have a junctional tachycardia, which is a focal mechanism. If you were to pace exactly at the time of the HIS, you will not be able to reach the HIS because the activation wavefront is coming towards you and it will block. Hence, you will not invade the cycle length or not invade the automaticity of the junction, and it will proceed without you being able to reset it. Then going at shorter cycle lengths, so beyond HIS refractoriness, you can also get important information by giving earlier PACs. Here you see again a slow fast AV NRT with an extra stimulus during non-refractory HIS period. What happens is that you can invade the fast pathway now anterogradely and activate and block the retrograde fast pathway because it's now refractory again, and you will terminate your AV NRT. So this is actually a sign also of a reentrant circuit. You block in the other pathway, so it will terminate. So this is something you can regularly see during slow fast AV NRTs. If you were to do the same in junctional tachycardia, there will be a different pattern because now you will be able to access the focus of the junction and reset it for a short while, hence advancing the subsequent HIS. And here is the Venn diagram, or the Lewis diagram that goes along with it. So you will beat the focal automaticity of the junction, and speed up the His of this beat. You have to be careful, of course, if the patient has the dual AV physiology, which can also co-occur. So it will be a pitfall. You have to really look closely to the timings at that point in time. And this is an example of atrial extra stimuli you can give during an orthodromic, during an antidromic CMT, so an AV-RT. Either you stop the circus movement from going on because you terminate it in the atrium, or you can delay and reset the whole circuit. As you see here, the subsequent His and atrial activations have been reset for 20 milliseconds, more or less, without affecting the activation sequence. So that's all about the atrial extra stimuli, but you can also decide to do atrial overdrive pacing. So stimulating the circuit at 20 or 30 milliseconds of shorter cycle length, and then see if you haven't trained the circuit, what happens if you release. So here is an example of one of the patients with an AV-NRT again. So you stimulate at 365 milliseconds, 20 milliseconds faster. You will block anterograde or retrograde conduction through the fast pathway, enter the slow pathway towards the His, and then you will see that there is an AHA response, which is typical again for an AV nodal or an orthodromic CMT, of course, but in this case it was AV nodal. And of course, what then is very important to look at is the VA linking phenomenon. So you look at the return cycle of the entrained beat, and then you compare the VA interval to the VA interval of the tachycardia itself. So of course we know in AVRT and AVNRT these will be the same, and in AT this can vary, of course. Now, atrial overdrive pacing in patients with junctional tachycardia will look a little bit different. As you can observe here, the last paced beat gives rise to an H and then an A, but the next beat will also be stimulated by, will emerge by itself, so you will have an AHHA response, indicative of junctional tachycardia. Now, in AVNRT, we often are faced with additional conduction delay after the reentry circuit, so the so-called low common pathway, which is important to recognize also for if you want to ablate the tachycardia later on. So how do we do that? In your AVNRT, in this case it's a slow-fast AVNRT, judging on the first retrograde atrial activation. You measure the retrograde conduction from His back to the atrium. In this case, it's 50 milliseconds. Now, if you were to stimulate the ventricle at the same rate as the tachycardia was, you should be able to see a similar HA interval if there's no additional conduction delay. So if there's no lower common pathway, these two would be the same or more or less the same. An arbitrary cutoff of 15 milliseconds has been published. So in this case, there's no argument for a lower common pathway. Probably this is one of the most common phenotypes that we have in slow-fast AVNRT, and you will often have one-to-one conduction during the tachycardia, and the optimal ablation site is antero-superiorly also of the CS. Now, in patients with slow AVNRT, this may be different, and also in fast, slow AVNRTs. This is a patient with a slow, because first atrial activation is at the posterior septal site in the atrium. And here you now can observe that the spontaneous HA interval is 55 milliseconds, whereas if you pace in the ventricle at the same rate, this now increased to 90 milliseconds. So it takes longer for the stimulus to reach the atrium. And then this is due to an additional conduction delay just prior to the His bundle, as indicated in the top right figure. These patients may show 2-to-1 block to the ventricle, so that's important to recognize because it may fool you and think that you maybe encountered a junctional tachycardia or something else. But it's a well-known finding in patients with atypical AV-NRTs. The ablation site is also a little bit higher up, successful ablation site, so that's also important to take along when you want to start ablating. Then a little bit about broad complex tachycardia. This is a case report of a 27-year-old lady with palpitations, and she presented with a broad wide complex tachycardia with 1-to-1 VA conduction. Of course, there's the differential diagnosis of VT, but also SVT with aberrancy or an antidromic AVRT. So how do we approach this? On the right side, you see that the sinus rhythm, beat and conduction is actually pretty normal. Don't see any pre-excitation. HV is normal. So, how to go about. So what you then can do is, again, atrial overdrive pacing at a slightly faster heart rate, and then look at the return cycle. First, what you can observe that there is a slight fusion of the QRS complex that was entrained and that was not entrained, and the response that we then observed was it looks like a AVVA interval, but this is a pseudo AVVA interval as the investigators performed his refractory extrasystolic pacing, and they could terminate the tachycardia from the atrium. So this means that this is an antidromic AVRT with a very long AV time, conduction time, so decremental property, so it's a pitfall. Usually you would expect an AVA return cycle, but in this case it's a pseudo. And it was successfully ablated from the tricuspid valve area. So this is an example of a Maheim fiber tachycardia antidromic. And what you may want to look for is the retrograde conduction to the A. It may vary. On the left side, the retrograde conduction passes over the right bundle to the node and back to the atrium, hence having a shorter VA time, whereas if you have a refractoriness in the right bundle, it has to travel across the septum to the posterior vesicle, and then the VA time will be longer, and also the QRS morphology will slightly differ between those two situations. Now, the last slide I want to show you, this is a case of VT. You see on the right side the broad white QRS complex tachycardia with 1-to-1 VA conduction and Purkinje potential preceding the ventricular activation. And if you now move to the left side of the slide, you see that there is atrial overdrive pacing resulting in HV response, AVVA response, indicative of VT in this case. So I hope to have persuaded you that atrial pacing maneuvers during sinus rhythm and during tachycardia have crucial importance to understand what is going on. Like Mika said, there is not one pacing maneuver that is to go for. You have to really combine everything, and also the ventricular pacing, of course, which will come later. You may unravel perinodal areas of slowed conduction, and they are highly relevant for your ablation targets and strategy. And atrial entrainment during wide complex tachycardia may discriminate SVT from VT. Thank you.
Yeah, it's sometimes really tough to stay focused and to stay in all these electrograms. So for those of you who want to join the PFA session next door, still welcome to do so. Otherwise, we're going to discuss the pacing maneuvers together, and I think we're going to proceed also for the sake of time to welcome Greg Michaud from the Mass General in Boston from the US, and it's going to be about the ventricular pacing maneuvers. So very warm welcome, Greg.
Thank you, and thanks for hanging in there in this last session. Let's see here. It's loading up. There we go. Some general disclosures, but nothing related to this topic. So we're going to talk about ventricular pacing maneuvers to sort out SVT mechanisms. These are sort of the go-to maneuvers that you often try during SVT. Obviously, I'm not going to talk about dissociation, so you can dissociate from the his Purkinje system or the atrium with ventricular pacing, which eliminates ORT from the mix. But we're going to talk more about sort of resetting our entrainment when the his is refractory or PVCs when the his is refractory. And that's your choice. I mean, you can PVC scan throughout diastole to look for the response there. And what are you looking for? Particularly that during his refractoriness, you're looking for whether that advances, delays, or terminates SVT. So advances or delays the A or terminates SVT with block to the atrium, which tells you it's basically ORT. Still look, if it's earlier than his refractoriness and it blocks to the atrium, then you know at least it's not atrial tachycardia because you didn't pull in the A first, it just blocked. Ventricular overdrive pacing during SVT is really the go-to maneuver that I use now because you could scan PVCs, it's fine, there's nothing wrong with that at all. But when you do ventricular overdrive, you'll see at the beginning of that drive, if you do it correctly, you get a lot of PVCs that are his refractory right in a row, and you can interpret that. And what are you looking for? Well, you're looking for the response following entrainment if it doesn't terminate the tachycardia, and that's either an AAV or an AV response. You can measure the stim-A VA difference and the post-pacing interval tachycardia cycle length difference. You can look during the zone of fusion, which is something we worked on some years ago, the very beginning of the drive, to see what's happening in that particular part of pacing. Don't forget, you need to sync your pacing. So this I see all the time, where people just come on pacing, they don't find an electrogram to sync to, and when you turn on pacing, it terminates the tachycardia because it comes in at a random interval. You want it to come in just barely before the tachycardia, right before, so that's almost 100% of the tachycardia cycle length here before your stimulus comes on. And you can set that. You can set it at 80, you can set it at the full S1 interval, and don't pace too fast. If you pace 20 milliseconds faster than a stable tachycardia, you will be able to tell the difference following pacing. So this is just something to remember at the beginning of your pacing. Here, everyone knows this slide. Here's a PVC that's coincident with the his depolarization that terminates tachycardia without conduction to the atrium. Everyone knows that's ORT. How do I know that that's a his refractory? There's a couple ways I can tell. First, look at the surface. If you know what the paced beat looks like in sinus rhythm, you'd know that that's fused, and you can tell that by just looking at the surface. And you can also look down here. There's an antegrade his bundle at the tip of that arrow that is coming just after the pacing stimulus. There's no way the pacing stimulus produced that his bundle, right? So that his bundle came the normal way, antegrade, and the pacing stimulus then cannot penetrate the his because it's already been depolarized. How does that work then? So this is sort of a depiction of that, where you've got your pacing from here. This is, say, a right free wall accessory pathway. You produce an antidromic wavefront, which collides with the previous orthodromic wavefront that came through the his bundle and right bundle. So there's a collision point there that doesn't allow you to get any further retrograde. So you can't get through the AV node retrograde when it's his refractory. However, the orthodromic part of that will proceed to the pathway, and if it's refractory, it blocks, and you don't get an atrial signal, right? So that's the explanation. There's only really one explanation for that if it's not fortuitous. It had to block in the pathway, and that's why it's actually a diagnostic finding. What if the same thing happens and you put in a his refractory PVC like the one here? Again, you can see the his is here, it's antegrade, it comes on time. The pacing stimulus is slightly before that. On the surface, you may not be able to tell that's fused. That's hard, but you have an intracardiac to help you. And what happens? Well, the tachycardia is 360, but the interval following that PVC is 420. So you actually delayed the next day. That's also a diagnostic finding. You terminate without affecting the A, or you delay the A. There's no way it could be anything else.
Even if you advance the A, although it's not diagnostic because that could happen over a bystander, it pretty much tells you that it's ORT in almost every case, even if it's not reset. If you show resetting, then that's pretty diagnostic. If you don't, you've got still a very, very high chance, because what's the chance that there's a bystander? Very, very small. Overdrive pacing is another way you can do it rather than PVCs. And then you can look for a lot of the same things. You look for a VAV response, which, by the way, you can do with a PVC. And you can look for a VAAV response as well. So here's an example of an AAV or a VAAV response where the pacing cycle length drives the tachycardia here. Each of these atrial beats is being driven by pacing. And when tachycardia resumes, it starts with an A. So this is a VAAV response. The other thing you'll notice is the atrial activation changes, right? Because when you're overdrive, it's like overdriving a focal mechanism. So you're going retrograde through the AV node, so that atrial activation sequence is going to look exactly like pacing in sinus rhythm with activation through the AV node. And that's what happens with a VAAV. Unfortunately, you don't see this usually because most of the time during atrial tachycardia, when you pace, you get dissociation, which is useful, but you won't see this response as often. With AV nodal dependent mechanisms, you will see this response every time, where the V produces an A followed by a V, not like the opposite where we saw an A and then another A and then a V. And this is seen with every AV nodal response, with every AV nodal dependent. It doesn't necessarily tell you whether it's AVNRT or a pathway, but it tells you that it's AV nodal dependent. It's a very reliable finding. You should look for that. You can get responses that look like one thing but turn out to be another. And the big clue here, remember I said when you pace and you get a true AAV response, the atrial activation sequence will change unless the atrial tachycardia is coming from exactly where conduction through the AV node would be. This doesn't change at all. That atrial activation sequence looks identical to the tachycardia when you're pacing. And if you do the measurements, which you should always do, you'll find out that V drives that A and that V drives that A, because this interval right here is 410. So that's the pace cycle length. That's a pseudo VAAV. It looks like a VAAV until you do the measurements. There's some other things you can look at. I can leave this here just for your reference. You can go back and later and look at that, but we're going to focus on the pacing maneuvers. So the other thing you can do is measure stim A minus VA. And way back when, I can't even believe it was this long ago, but it is, we looked at septal ORT, so a septal accessory pathway. And remember, this was really designed to differentiate septal pathways from AVNRT, not necessarily left free wall because you have activation sequence to help you there. So you have a septal ORT, and you're trying to figure out, or septal or concentric activation, which is it? Well, if you look at the stim A-VA difference and you lose 85 milliseconds as a cutoff, all of the AVNRTs had a long one, all of the septal ORTs were under that, but there were some that came pretty close to that 85 millisecond line. Post-pacing interval minus tachycardia cycle length, a bigger gap between the two groups, and 115 worked out. And that number's come up again and again. Other people have looked at that. It's a pretty good number, turns out, over time. So that's always it. If it stands up to the test of time, then it's probably a pretty good number. So here's an example of ORT using a septal accessory pathway. We have overdrive pacing. There's a couple things you'll notice. One is on the surface, you're in training with fusion. So if you knew that, you'd know immediately this is ORT, because you can't entrain AVNRT with fusion. But then on top of that, you can measure the difference between stim A and VA, and they're only 5 milliseconds off. You can measure the difference between post-pacing interval and tachycardia. They're only 40 milliseconds off. And the post-pacing interval, the post-pacing interval is very short. So there's a bunch of things on this slide that scream to you that this is ORT. The short post-pacing interval, the short stim AVA, and you're in training with fusion. And then I'll show you something else where you're driving an orthodromic hiss at the pace cycle length. So here, we have a clear-cut example of AV and RT, right? We overdrive pace, we accelerate the tachycardia, we do our measurements, and we see the stim AVA is 130 milliseconds, and the post-pacing interval minus tachycardia cycle length is 170 milliseconds. Those intervals would tell you this is AV and RT, correct? Correct. But in this case, it's not correct. Because if we go to the beginning of the drive, and this is the importance, don't only look at the end of the drive, there's information at the beginning of the drive as well. You'll see that the very first paced beat that shows any degree of fusion, right here, delays the next day. So this is ORT, and it's using a decremental accessory pathway. And that's one of the pitfalls of the post-pacing interval. But you can figure it out still, often just by going to the beginning of the drive and looking at that, because that will often give you your answer. So that when the tachycardia cycle length, or the VA time, is more than 40% of the tachycardia cycle length, you have to be wary that you may encounter that pitfall of the decremental accessory pathway. If it's a short post-pacing interval, even with a decremental, and you'll see that, then it's a pathway. If it's long, then you need to go back, either put in His refractory PVCs and see whether you can affect the tachycardia, or just go back to the beginning of the drive and look at all the fused beats that you had there. That'll give you the answer. There's some other modifications you can correct for the delta AH. So the dramatic example would be you come off pacing and you go down a slow pathway, then tachycardia resumes over a fast, so you'd want to correct for that difference. But if you pace very close to the tachycardia cycle length, you won't run into that issue very frequently of prolonging the AH. Just like we heard earlier, if there's data that's confusing to you, go to the earliest A, or pace from the base and apex, or you can do differential entrainment from the base and apex, or you can just go closer to the source of the earliest atrial activation. You can also look at induction of tachycardia and use the same values. And single PVCs during tachycardia, you can take all of this and apply it to those. Here is the example of the orthodromic His. This is another septal accessory pathway. And you can see that that stimulus, or V, drives that A. This V drives that A. And this is the last one driven at the pacing cycling. So you're not producing a retrograde His here, you're producing an antegrade His through the circuit. And that is an indication that there's fusion, and you can see the fusion on the surface, but it's not always easy to tell. So if you have a clear-cut His, you can go back and measure it. And if you drive that His at a long stim to His time, and it's at the pace cycle length, that tells you that you're in training with fusion. Real quickly, the fusion zone of pacing, it's all the same ideas as the thing I showed you with PVC, but you get a bunch of PVCs in a row that you can inspect and try to see if anything happened. We define that as all of the ones that clearly are fused and the first one that looks like a stable pace morphology. And it doesn't depend on entrainment, so if it breaks and something happened during that zone of fusion, you still have a pretty good diagnosis. Here's an example of the atrial activation advancing with fusion. Here you have we marked all the fused beats for you here, and then this is the first one that looks paced and doesn't change after that. And before that, one of these fused beats accelerates the tachycardia way back here. So that's an example of a pathway. For AV and RT, it happens after that zone. So once the fusion stops, it's 1, 2, 3 more beats later that you tend to see the tachycardia be affected. So again, RV pacing is going to help you make the diagnosis in most cases if you haven't already made it. You may never get a diagnostic finding. Look at the surface for fusion. That can be really useful. And then pace close to the earliest day if there's any ambiguity about the numbers you're looking at. Thank you.
Thank you very much for the excellent presentation. If someone has a burning question, we have 1 minute. Otherwise, I'm afraid that for the sake of time, we have to continue and apply it all for the diagnostic approach to a regular broad complex tachycardia with one-to-one VA conduction.
Thanks a lot, Marta. So usually when I have a presentation to make, I go to PubMed, I write the title, and I read the first review article about the topic, and I found tens and tens of papers about one-to-one VA conduction with narrow QRS complexes, but 0.0 with wide QRS complex. So I didn't have any review to help me, and I had to dig into all the maneuvers. So for the sake of time, I could not describe you everything, and plenty of things have already been described so far. So just to start, what are we talking about? We are talking about broad QRS complex tachycardia, which will be either VT or SVT with aberrant conduction. Antidromic AVRT, I would have written better pre-excited tachycardia, and SVT with a bystander accessory pathway. Just keep in mind that the context matters. If you have a wide QRS complex tachycardia in a 12-lead ECG, the probability of being VT is 80%. And if the guy has a prior MI, it's more than 90%. But if you have a young patient with no history of cardiac disease, palpitations with sudden onset and termination, the most likely diagnosis will be a VT. And also, almost half of the VTs may have a one-to-one retrograde VI conduction. We are EPs, we'll discuss about EP, but quickly, if you have a wide QRS complex tachycardia with a one-to-one conduction, look at the ECG. You can look if you have PVCs that are similar to tachycardia pattern, if you have a pre-excitation, a pre-existing bundle branch block. For example, here you have PVCs that look like exactly the wide QRS complex, so you can know that it's a VT. I will not go into that, but you know that the morphology of the wide QRS complex can help you. And also, adenosine can help you. If you terminate the tachycardia, you can know that it's AVRT, AVNRT, or adenosine sensitive VT. You can diagnose ATAC or flutter, and if you have no effect, it's more probably a VT. Now let's go endo. First, look at the signals. And the question would be, is there a His potential before the V? And here you can clearly see a His potential before the V. And if you have an HV in tachycardia, which is longer than the HV during sinus, it's SVT. EP is made of exceptions, so there is always an exception, and the exception is bundle branch reentry, where you will have an HV that will be longer in tachycardia than sinus. And if you have HV during tachycardia that is smaller than sinus, it's VT, or a negative HV, it's VT. Exceptions, EP. So you can have a pre-excited VT that will, pre-excited SVT that will give you a negative HV or a shorter in tachycardia. Then also look at the cycle variations. Are the VV leading the EAA or the opposite? If you have VV leading the AA changes, you have typical AVNRT, AVRT or VT. If you have AA leading the VV, it's atypical AVNRT or ATAC. Also, exceptions, you have the bundle branch reentrant VT where the HH will induce VV changes. Look also at the VA interval. If you have a short VA interval, it's ATAC or typical AV and RT. VT is very unlikely unless you have a very slow conduction from the V to the A, and by chance the A is occurring at the same time than the following V. If you have a long VA interval, it's more ATAC, AVRT, atypical AV and RT, or VT. Also, keep in mind that a concentric atrial activation sequence can occur in SVT and VT, but if you have eccentric atrial activation sequence, practically excludes VT unless you have a VT plus a bystander accessory pathway. The guy is not lucky. Then atrial overdrive pacing will be a very important maneuver. You will pace from the atrium and you will look at two things. Raquel told about that already. The change of the QRS morphology and the first return EGM of the tachycardia. So if you have a VT, so the V leading the A, then you will do atrial overdrive pacing, so you will capture the ventricle. So you have a wide QRS complex at the beginning, narrow QRS complex or a different QRS complex from the VT, and then the tachycardia resumes, and you end up having your initial wide QRS complex tachycardia. And you can look at the resumption of the tachycardia, you have an AV-VA response. On the other side, if you have ATAC, for example, or SVT, you will have the same wide QRS complex tachycardia, at the beginning and the end, and when you stop the pacing, you will have an AVA response. Some examples here, but I will, so AVVA, different QRS morphology, so it's VT, no change in QRS morphology, AV, so it's SVT. Exceptions, EP, so the exception will be, once again, belt and branch reentry, so just a special focus. You have the typical LBBB or RBBB pattern, the H before the V, then if you have a left bundle branch block pattern going down the RBB, then the V, then the LBB, then the his, you may have a retrograde his activation, so this negative HV, retrograde disactivation, sorry, but you will have a HV during tachycardia that is going to be longer than HV during sinus rhythm. No change in QRS morphology when you do atrial overdrive pacing, and the HH modifications precede the VV, as I told you, and we'll discuss that later. You will have a short PPI when you're pacing from the RV apex. Also keep in mind that when rapid atrial pacing dissociates the atrium without influencing the tachycardia cycle length of the QRS, or the QRS morphology, it suggests it's VT, but you can have some exceptions that you can read. One PAC, it's enough. Sometimes it's enough. Raquel already showed you that. You see here one PAC. We are advancing the following V without changing the morphology. So this indicates VT. Another example here with a PAC. So you have a one-to-one VA relationship. You have the A, which is here. You have central atrial activation from the sinus 910 to the sinus, the distal sinus. Atypical QRS pattern, which is unlikely to be SVT. No his deflection before in the his lead. So it's a VT or a pre-excited SVT. Then you see that the PAC advances the following QRS complex with the same morphology, so it looks like it's more a pre-excited SVT, and you have a very good PPI from the distal CS, and the advanced ventricle advances the subsequent atrium, so this is indicative of antidromic AVRT. So look at that, just with one single PAC, you can have the full diagnosis. Also, some exceptions with the PACs. If you want, you can take a picture, but if you put for antidromic AVRT a less late or a short, more closer PAC, you will have different effects. But for the sake of time, I will go more quickly because you can also do pacing maneuvers from the ventricle. Greg already showed that. So if the atrial overdrive pacing told you it's a VT, and you have a long PPI, you can have that for left-sided VT, and you can have a short PPI for bundle branch reentrant VT, because the right ventricle is part of the circuit. And for SVT, you will have a long PPI for AV on RT and ATAC, and a shorter one for AV RT, and even shorter than 110 if the right ventricular apex is part of the circuit in case of right-sided accessory pathway or LBBB. Also, you can analyze the response at the end of the ventricular pacing. As Greg told you, you have a VAV response for VT, and a VAHV or VAA-HV response for AVRT, AVNRT, or ATAC. Also, when you do overdrive ventricular pacing that fails to accelerate the atrial cycle length to the pacing cycle length, meaning that the V are dissociated from the A, VT and AVRT are excluded, and ATAC is the most likely diagnosis, although AVNRT is still possible. So it was not easy. For the sake of time, I had to do some shortcuts. I didn't discuss about the Mannheim fibers and so on, but there are dedicated reviews about that. So first, look at the ECG. Baseline ECG, QRS morphology, adenosine. Next step, the endo. Do you have a His potential? I didn't tell you, but is the His activated from the proximal to distal or distal to proximal would be also very helpful. The AA and VV variations, the VA interval, the atrial activation pattern. Then you can do atrial overdrive pacing. Look at the QRS morphology change and the resetting if you have AVVA or AVA response. You can also just have one atrial extra stim. Look at the subsequent V effect and A effect. If you reset the tachycardia or terminate it. It's more likely an antidromic AVRT. Then you can go for ventricular overdrive pacing. If you have a VAV response, it's a VT. Unless you have a bundle and branch 1 VT, you have a short PPI at the apex. I'm ashamed, don't take a picture because there are plenty of, no, you can do it for sure. But there are plenty of shortcuts, plenty of exceptions that are not written in this slide. So it's not the truth with a big T, okay? It's just a shortcut of EP that I try to make in just 10 minutes. And for the ventricular overdrive pacing, then if you excluded VT, if you excluded bundle and branch reentrant VT, you can do all that Greg, Raquel, and Michaela told you about the other maneuvers from atrial pacing, ventricular pacing, each refractory period pacing, and so on. Thanks a lot.
So thank you very much. Thank you as the audience. I think we really don't have any time because I get message after message that the session is over. I want to be honest with you 2 times. One time is, for this, some of those parts of the presentations, my brain, obviously at this point in time, was too slow. So I'm really looking forward to review the presentations, which is possible from tomorrow on ESC 365. And I think this is one of the